Alright guys, can you all hear me? Can you all see me? Quick feedback. Can you all hear me? Sir, why weren't you there yesterday? Okay. Right. We have our BLS class only on Monday, Tuesday, Wednesday, no? के notes कहाँ से buy करने हैं? Right. So we'll find to give you the answers of every single question that you have. Fine. Okay. So let's start the session for today, and then as we move across, we'll try to understand that what are the better objectives and the better options that we have for various aspects. Okay. So continuing the series on the BLS only, today we'll be talking about a very important topic that you will manage in your wards as well as in casualty. And this is something which is going to be quite distressing for you, especially when you're working as an intern, because you will have a patient who will land up to you with burns, right? So today's topic that we'll be talking about is going to be about burns. Ek second, I think okay, fine. Okay, right, great. Now, when you talk about burns, we'll talk about the management of the burns. We'll talk about how do you assess the burns and all that. Hi, Rathod. Good evening. Good evening. Good evening to all of you who have just joined in. Today's topic for BLS that we have decided to take. One second, guys. Yeah, it is going to be on the burns. Okay. Now let's. Okay, fine. We'll look into it. Okay, don't worry about it. Acha. Whenever a patient of burns come, no, we have a set protocol that how do you want to assess, analyze, and then treat the patient of burns. So that is what we're going to discuss. So talk about first the basic protocol when a patient with burns is going to arrive to us, right? Now the first thing that I'm going to do as soon as a patient of burns is going to land up into the casualty is to perform the primary survey. It is to perform the primary survey. We have discussed in detail in the trauma series that what is a primary survey, that you have A, B, C, D, E. We spoke about the basic objective of doing a primary survey. It is to rule out any immediate life-threatening injuries. Okay? Now, when you do the primary survey, as you continue to perform the primary survey consists of the parts that is going to be airway with that is airway with cervical spine stabilization, breathing with ventilation, circulation, then you have hemorrhage control. D is going to be disability limitation. E is going to be expose and examine. So these are the protocols that you will be following for a primary survey. Now, as the primary survey continues to happen, I am now going to look into the burns segment also. That means the patient is presented with burns, right? Now, the first thing I'm going to do is I'm going to place an oxygen mask, right? So I'll put a face mask, place a face mask. So you're going to put a face mask onto the patient. You'll put a mask and then give 100% oxygen, right? With 100% oxygen. So we don't know what is the exact component of burn that has occurred. Is it an inhalational burn? Is it a scald burn or anything? We normally say that any steam that would have gone in or any fumes that have gone in could cause some amount of injury or damage to the airway. It should be oxygenated, so you should provide that additional support to the patient. Your patient remains stabilized. So I will give a face mask with 100% of oxygen. Now all patients of burn, specifically with significant burn, you have to secure 2 large IV cannula. Now when you say 2 large IV cannula, we have already spoken about it. 16 gauge is preferred over 18 gauge. So ideally I should put a 16 gauge needle. If you do not have 16 gauge needle, you can go ahead with 18 gauge needle as well. Now all patients of burns who comes to you, the injection of tetanus toxoid, that is TT, that is 0.5 cc intramuscular should be given, right? So it's a prophylaxis, right? So injection of TT, that is tetanus toxoid, is given as a prophylactic component. So I'm going to put a mask, oxygenate the patient, secure 2 large IV cannulas, give a TT shot, and this is what you have done in the immediate form that you've seen. Now, as you are looking into it, you have to look for the warning signs, right? So what are the warning signs for intubation? We look for the warning signs for intubation. So when are you going to intubate a patient who has landed to us in casualty with burns? So what are the warning signs for intubation? Number one, if there is presence of hoarseness of voice. If there is hoarseness of voice, that can be because of laryngeal edema, that can be secondary to inhalational burns. If there is presence of stridor, specifically you're talking about during inspiration, we call it as the inspiratory stridor. So if there is presence of stridor during inspiration, if there is an evidence of facial burns, if there is evidence of facial burns, and if there is presence of severe wheezing on auscultation. If there is presence of severe wheezing on auscultation, if any of the following signs are available, you have to intubate the patient immediately. So warning signs which will warrant you for intubation: number one, presence of hoarseness of voice, inspiratory stridor, presence of facial burns, and if there is wheezing associated with it. If there is wheezing associated with it, then I would like to intubate my patient, right? Now let's say, so this all comes under the component of primary survey only. While you're doing primary survey, you're doing this as well as you're looking for this. Once you have gone past this stage, right? Once you've gone past the phase of the primary survey, then begins our secondary survey to look for all potentially life-threatening injuries. So the next thing that I'm going to do is to perform a secondary survey. I'm going to do a secondary survey. We're going to perform a secondary survey. Now, in the basic goal of the secondary survey is to rule out any potentially life-threatening injuries. We're going to rule out any potentially life-threatening injuries, and that is what we'll do in secondary survey, right? Now, in the secondary survey, our primary goal in the secondary survey, it is going to be the assessment of the extent of the burn. It is the assessment of extent of burn. Now this is where you will also decide whether you're going to admit the patient or not, whether you're going to transfer it to a burn unit or not. All that will be taken care in this assessment. In fact, this has been your exam question, that is your competitive exam question, that when would you like to do the assessment of the extent of the burns, or percentage of body surface area burnt is assessed on which part of the survey it is expressed or it has been evaluated in the secondary survey while you're performing it, right? Now, in the assessment, we will look for the total body surface area burnt. We'll talk about it, how we do it. But for now, you remember the assessment, once you have done, I can get back to two components. That is what we call it as significant burn, right? What is the definition of a significant burn? It is the total body surface area burnt. If the total body surface area burnt is more than 15%, it is what we call it as significant burn. If the total body surface area burnt, if the total body surface area burnt is less than that of 15% of the total body surface area, this is what we call it as a insignificant burn. It is going to be an insignificant burn. For an insignificant burn, it is going to be local management. So that is your moist dressings and all that. So here it is only going to be basic wound care. We'll discuss in detail that how do we do a wound care. But if it is less than 15%, it is going to be only restricted to a wound care component. But if it is more than 15%, then you have to go ahead with resuscitation. You have to go ahead with resuscitation of the burn, and obviously the fluid of choice here is going to be Ringer lactate. I will also put the patient on a Foley's catheter. The Foley's catheter is deployed in order to measure the urine output so that I can assess the response to the resuscitation which is present. I will also do a wound care management here. We'll do a wound care management and obviously look for the extent of the burn that is being provided. Okay? Now, once you have decided whether you have a significant or an insignificant burn, you have sometimes even an insignificant burn, if the depth of the burn is more, then you have to resort for the surgical component, and that is what we're going to discuss in this, right? Let it be significant or insignificant burn, you have to go ahead with wound irrigation and debridement. You might have to land up with wound irrigation. You have to look for wound irrigation and debridement. You have to look for the wound irrigation and debridement. So it is the wound irrigation and debridement has to be done. Let it be a significant or an insignificant burn, right? Now, once the wound debridement is done, you will look for whether it is a viable or a non-viable tissue. You look for it as viable or non-viable. Whether it has got a non-viable tissue or whether it has a viable tissue. Now, if it is a non-viable tissue, then obviously you have to resort to skin grafting or flap reconstruction. So here either you have to go ahead with skin grafting or you have to go with flap reconstruction. Skin grafting or flap reconstruction. If it is a viable tissue, then it is going to be a local burn wound care. It could be a local burn wound care with topical agents and all that dressing materials which are going to be there. So our lecture is decide, or it is going to be based on this particular algorithm. A patient with burns, when he comes to your casualty, what are you going to do? You're going to conduct a primary survey. In the primary survey, you're going to look into ABCDE, then you do this, that is put a face mask, give 100% oxygen, secure 2 large IV cannulas, give a tetanus toxoid injection, look for warning signs for intubation. If this part is fine, they have no problem, you go with secondary survey. In the secondary survey, you see whether it's a significant or an insignificant burn. Based upon that, you look for wound management. This is all that you have to do in the context of burns. ठीक है, तो burns का मोटा मोटा जो objective है ना, इतना ही है कि patient जब आता है तो primary survey करना है. Primary survey के साथ साथ you have to make sure you have a good backup, that is oxygenation should be there, IV line should be secured, and make sure you have a stable patient. इसके बीच में you have to look for warning signs for intubation which we have mentioned. अगर वो नहीं है, you go into secondary survey. Secondary survey is the point where you look for the extent of the burn, you look for the percentage of body surface area burn, and based upon that obviously you'll go with resuscitation protocol. इतना ही है, इससे ज़्यादा कुछ नहीं है, so you don't need to bang your head against it. ठीक है. Now, when you look at the entire objective of the burns, ठीक है, so we'll take it in a context that how or what we are going to do in a secondary survey. Okay? As soon as the patient comes, so we talk about the burn management protocols. So we're talking about the burn wound management, right? Now, as soon as the patient is rushed to the casualty, now imagine you are posted on a casualty, a patient is then brought on a stretcher with the body, which is, let's say there's a recent, like in last half an hour ago, the patient had a burn. Like it could be a scald burn, that is hot water spilled and the, the entire area of that particular body is burnt across. So what do you do? Now, the first thing, any patient who's been brought to your casualty, obviously you've done the primary survey, you're now in the secondary survey. In the secondary survey, what are you going to do? The first thing, I am going to give a thorough wash. I'm going to provide a patient with the thorough wash. Now, there has been a couple of important points about the thorough wash. Number one, what is the objective of giving a wash? The objective of giving a wash, it is not to make it clean, it is not to make it sterile, no. It is basically to let it cool down. So the objective of the wash is to provide a cool down effect. It is a cool down effect. You don't want the heat to dissipate into deeper tissues, right? Now, because the objective is to cool down the wound, what is a preferred fluid for wash? Would you like to give crystalloids? Would you like to give colloids? Would you like to give tap water? What is it? Now, the objective is just to cool it down, right? I don't need to use any fancy fluids. I need something which is going to absorb that heat, and the best one that you have is going to be a tap water. Now, this tap water will always be found at a room temperature. always be found at a room temperature. Room temperature tap water is good enough to create a cool down effect. But there is a small disparity when you read Bailey, in this room temperature, they've mentioned as 15 degrees Celsius. That is a European room temperature. When you go into the Asian subcontinent, the room temperature is 20 to 25 degrees, which is also acceptable, but the concept remains the same, that you are going to provide that particular patient with a cool down effect, and a cool down effect can be done with tap water. Now, in order to cool it down, how long would you like to run the water? Would like to run it for 5 minutes, 10 minutes, 15 minutes, half an hour, 1 hour. If you run it for prolonged period of time, the patient can go into hypothermia also. So ideally, this has to be run for 15 to 20 minutes. It has to be run for 15 to 20 minutes. So I'm going to do a cool down effect by giving a wash. I will use tap water, and the tap water which we consider putting across here is going to be at 15 to 20 minutes of wash, right? So this is the first thing that you're going to do, that is with respect to the thorough wash. That is with respect to the thorough wash. Clear? So I hope everybody's clear. Why did we go ahead with wash? A quick feedback, guys. Is everybody clear with this? Just accessing the chat box. I hope everybody is clear that why are we giving a wash, what is the objective behind giving the wash and all that. Okay? Now, once you have given a wash, you would look for criteria to admit the patient in a burn ward. Okay? So we have the criteria for admission. So given the wash, now you will see whether the patient can be admitted or should be admitted or not. So what are the criteria for admission in a burn wards? Okay? Now, the first criteria that I can list it for the admission, if it is having a suspected, if there is a suspected inhalational injury. If there is a suspected inhalational, in simple words, I am saying if it is associated with a airway injury, right? So if there is a suspected inhalational or if there is suspected airway injury, that is where the first criteria for admission. The concept of admission is quite simple. If a patient cannot be managed at home, you have to keep him in the hospital. It is as simple as that. If there's an airway injury, there will be cause laryngeal edema. Laryngeal edema will cause severe distress, and severe distress or respiratory distress will lead to respiratory failure and death. To prevent that, I would like to admit the patient and monitor the patient at the hospital. The second one, if patient requires fluid resuscitation. If a patient requires fluid resuscitation, that means the IV cannula is put and you're running the fluid. अब patient बोतल लेके घर तो नहीं जाएगा ना, ऐसे पकड़ के अच्छा नहीं लगता ना. तो अगर patient, when do you say it is required? The patient is hemodynamically unstable, there's hypovolemic shock, you want the patient to be resuscitated. In those scenarios and lines, I would not like to send the patient home. I would keep the patient in the hospital. Now, if patient requires any form of surgery, now that surgery could be a debridement, it could be a skin grafting, or it could be an eschorotomy. Anything if it requires, you cannot send the patient home. I will admit the patient then and there itself. Then, very important, if the burns, I'm not talking about the percentage, but if there are burns which are present on hands, which have got very high risk for post-infection, face requires good monitoring and care, feet for the same reason as hand, and perineum. All these are notorious sites for infections and difficult management. If there is burn in any of these areas, I would like to admit the patient and address those particular components, right? So that is another one. Now, if the patient has any psychiatric illness or poor social background, where I feel the care at the home cannot be given to the level or the standard that we require. Okay? Now, if there is any suspicion of non-accidental, if there is any evidence of non-accidental burn, right? If you're suspecting a foul play, if there is, some, thing that you think that is not accident, somebody has wantedly done it, in those cases also you have to admit the patient for a medico-legal reason, right? If burns in extreme of age, burns in extreme age. So when I say extreme age, in an extreme age, who qualifies? The criteria for extreme age is age less than 10 years or age above 50 years. So either less than 10 years or age above 50 years will be qualified as your extensive burns, or I can say extreme of ages. Okay. Now, if there is any potential sequelae, right? If it is associated with potential burns associated with potentially serious sequelae, potentially serious sequelae. So when I say potentially serious sequelae, in a potentially serious sequelae, we're talking about examples like electrical burns. Now, in electrical burns, the patient can have myoglobinuria that can result in acute tubular necrosis, renal failure, and multiple, obviously, post-electrical shock MIs can happen. So, in those patients, I would not like to send the patient home. Any alkali burn. We all know alkali burns are associated with liquefactive necrosis, which is more dangerous, and or any other form of acid burns. So anything where you have possible potential serious sequelae, in those I would not like to send the patient home. So this is what is currently advised as the criteria for admission in a burn wards if the patient presents to you with any of the following. Okay? Now comes the assessment of the percentage of body surface area burnt, right? So the third thing is the total body surface area, total body surface area burnt assessment. Talk about the total body surface area burnt assessment is what is step number 3. Now for this, if you say what is the most commonly used rule, right? So overall most commonly used rule is what we call it as the Wallace rule, or also called as the rule of 9. So if I say the most common rule for assessment, it is what we call it as the Wallace rule. The Wallace rule is also popularly referred to as the rule of 9. It is popularly referred to as the rule of 9. But if they ask you what is the best method or the best rule for the assessment, then the answer is going to be the Lund and the Broders chart. It is the Lund and the Broders chart, right? So if they ask you what is the most common rule for assessment, that is going to be Wallace. But if I say what is the best rule for assessment, that is going to be the Lund and the Broders chart. It is going to be the Lund and the Broders chart. Okay? So we'll start with the Wallace rule, that is the rule of 9 for the assessment of total body surface area burnt. So we'll start with rule of 9. So rule of 9 is what we call it as the Wallace rule. Now, there is hardly any exam question paper where you would not have a question on burns, and especially when they want to ask a question on burns, they're more concentrated on the part of how you assess the total body surface area burnt, and that is going to be your Wallace rule. So what we are going to do is I am going to split them into two components. One is the adult, another one is going to be child. Okay? Now when you look at the adult's structural frame, this is the head of the patient. Let's say this is the head of the patient. This happens to be the neck of the patient. This is what we call it as the trunk of the patient. Now when I say trunk, trunk indicates both the chest and the abdomen. The abdomen and chest together is what we call it as trunk. This is what we have the representation of the upper limb. This is the representation of the upper limb that we have. This is going to be the palm. Just to give you a significance, the palm accounts for 1%. This happens to be the lower limb of the patient. This happens to be the lower limb of the patient. And this is what we'll consider as perineum. Just for the sake of understanding, we've given you an objective of perineum, which is going to be present, right? Same thing, we are going to equate that to a child also. So in a child, the tinge of difference that you will see across, that in child we do not consider perineum as a component. Okay? So in a child will not have perineum. So perineum component will not be considered for child. Okay? Now come back here. So in an adult, when you are calculating the percentage of body surface area burnt, the head and neck together, the head and neck both, the head and neck together account for 9% of the total body surface area burnt. That is the head and neck, right? Then you have the trunk which is present, that is chest and the abdomen on the anterior surface, the anterior part of the chest, the anterior part of the chest as well as the abdomen. So I've said trunk together. The entire trunk is going to be 18%. The trunk is going to account for 18%, that is going to be anterior, and 18% that is going to be posterior. Matlab, the entire anterior is 18%, the entire posterior is going to be 18%. Okay? So 18% anterior, 18% posterior. Then you look at the upper limb, right? From the shoulder girdle all the way to the tip of the finger. All the way to the tip of the finger. This is what we call it as the upper limb. Now the upper limb is going to account for 9%. And specifically, if you look at the palm alone, specifically you look at the palm alone, the palm accounts for 1% of the total body surface area burnt. So it is also called as rule of palm, because based upon the palm you can see that how much amount of body surface area is going to be burnt, right? Then you have the perineum, right? So perineum is going to account for 1%. The perineum is going to account for 1%. And the last but not the least, you have the lower limb. The lower limb is all the way from the anterior superior iliac spine to that of the tip of the finger, toes. So the lower limb is going to account for 18%. The lower limb is going to account for 18% each, right? So look at that. So you have 2, 9, 9, 18. Another 9 you have at the head and neck. The 18 is anterior, 18 posterior, that is 36. 18 plus 18 is 36. 36 is going to be your 72. 72 plus another 18. 72 plus 18 plus 9. No, this is 9, 9, 18. 18 plus 9 is 27. So you have altogether, it is going to come, 18. So 1% perineum, total 100%. Okay? So if you add up all together, you will get 100% of the total body surface area that is going to be burnt. Same thing when you look at the child. The head and neck of the child. Child mein variation kya hai? The head and neck in the child is going to account for 18%. So child's head and neck is going to be of more, it is going to be 18%. The upper limb of the child remains the same, that is going to be 9% total. The upper limb of the child remains at 9%. The trunk remains the same, that is going to be 18%. The trunk, that is going to be a combination of both chest and abdomen in both child and adult. So when you look at the trunk, it is going to be 18% anterior as well as 18% posterior. It is going to be 18% anterior as well as 18% posterior. In child, we do not consider to have the perineum. So the the lower limb, that is from the anterior superior iliac spine to all the way to that of the toes, that is going to be your lower limb. And the lower limb is going to account for 14% each. It is going to account for 14% each, right? So palm here also in a child, it is going to account for 1% of the total body surface area burnt. So palm is also going to be 1% of the total body surface area burnt. And this is what we call it as the Wallace rule, or also called as rule of 9. Okay? Now everybody now understands that how do we assess the total body surface area burnt in a quick succession. Based upon this, you will never go wrong. Now once you've understood this, you need to understand what is the definition of a significant burn. When do you call a patient is now brought to you with significant burn? The criteria to call a patient is going to have a significant burn also depends upon the age of presentation. So we say, is the age less than 10 years? Is the age between 10 to 50 years, or is the age above 50 years? So we say if the patient is age less than 10 years, then we say more than or equal to 10% of the total body surface area burnt will be called as a significant burn. It will be called as a significant burn. But if it is the age is between 10 to 50 years, then we say more than or equal to 20% of the total body surface area burnt. More than or equal to 20% of the total body surface area burnt is what we call it as significant burn. And if it is more than 50 years, then the answer is same. That is more than or equal to 10% of the total body surface area burnt is what we call it as significant burn. Now, to avoid any form of confusion, what do you call it as a uniform answer? For a uniform answer, we say no matter what the age is, no matter what the age is, if a patient is presented to you with burn, the definition of significant burn will more than or equal to 15% of the total body surface area burnt. If they're not asking you age specific data, so irrespective of whatever the age you're going to talk about, if they fall into more than or equal to 15% total body surface area burnt, we can call it as significant burn. Otherwise, this is age specific data that we should be knowing about. Okay? So this is about the entire assessment that we have done. So we have done a wash, you have looked for the admission, you have done the assessment. Now you need to assess the burn wound per se. Okay? So the fourth one is going to be burn wound assessment. So the fourth criteria that we're going to follow here is going to be a burn wound assessment. So when you look at the burn wound assessment, so you need to understand that what is the depth of the burn, what is the extent of the burn, how much is the tissue damaged, is it viable, is it non-viable, is it reversible injury, is it an irreversible injury? So multiple questions that we have to answer. Now, in order to address that, the first thing that you have is something called as the Jackson's thermal wound theory. So we'll talk about the Jackson's thermal wound theory. Now, what is this Jackson's thermal wound theory? Jackson said that we are going to divide the burn into three distinctive zones, right? So what are three distinctive zones that you're going to be present? Let's say that this is the burnt tissue that we have. Okay, we'll just take even more lighter color. Wait. Okay. So let's say that this is a tissue that is burnt. This is a block of tissue that we have, and this block of tissue, let's say this block of tissue is being burnt. Now, as the tissue has been burnt, you will notice there will form three distinctive zones which are present, right? So the first zone of the burn is going to be a central zone which is present here. So this, okay, we'll highlight with a different color. So this is the zone which is going to be present right in the center. I'm not able to make a justification out of it. So what we'll do is we'll use our colors. Okay? So this is the first zone where you have the maximum impact of the burn that is created. Surrounding this area, there is another distinctive zone of injury which is going to be here, right? So this is another distinctive zone that is going to be created. This is the second zone around the first zone. Okay? So this is the second zone beyond the first zone. Then you have the one which is probably the most viable one, is what we consider that is going to be this zone. So the three distinctive zones that are being created in a burn. So the central one is the one which is going to have the maximum impact. So this is where the wound of the burn is created, and this is how it looks like, right? So the three distinctive zones in burn that are created, and that is what your Jackson's thermal wound theory basically tells you, right? So what are these distinctive zones which are formed, right? Now the zone which is present right dead in the center, this is what we call it as the zone of coagulation. This is what we call it as the zone of coagulation. The second, that is the in-between zone that is present here. This is what we call it as the zone of stasis. This is a zone of stasis. And the last zone that we have created here, it is what we call it as the zone of hyperemia. It is the zone of hyperemia. Emia means blood only, so this hyperemia is there. Okay? So three distinctive zones. You have the zone of coagulation, you have the zone of stasis, and then you have zone of hyperemia. You will notice that the zone of coagulation is a zone where you have maximum tissue damage. Now, because there's a maximum tissue damage, it is associated with tissue necrosis, right? So zone of coagulation, it is associated with tissue necrosis. This will have maximum damage. This will have maximum damage, and this is basically irreversible. So this zone has to undergo debridement. Okay? If there is a zone of coagulation, you will have maximum tissue necrosis, it will have damage, and this is irreversible condition, so you don't need to worry about it. Okay? This has to clear cut go with its dissection, right? You'll go and basically do a debridement and get rid of it. That is the zone of coagulation. Zone of stasis, it has got viable tissue, but then it is low potential. That means it can convert into the zone of coagulation. It can also become necrotic. So it consists of a viable tissue, and it has got poor vascularity. Right? Zone of hyperemia, on the other hand, has the maximum viable tissue. This has got a maximum. It has got the maximum viable tissue. So there's a good viability potential. It has got good vascularity. It has got good vascularity. And this depends. So basically why I'm telling you all this is the when we talk about in terms of the potential or the outcomes, we generally talk about whether the prognosis of that particular wound will be good or bad. That depends upon that what is the extent of each particular zone. Needless to tell you, if you have bigger zone of coagulation, that is more injury or more damage is going to occur. जितना ज़्यादा zone of coagulation होगा, उतना ज़्यादा necrotic tissue होगा, और जितना ज़्यादा necrotic tissue होगा, उतना poor viability होगा. मतलब उतना ही extensive, उतना ही बुरा wound होगा. ठीक है? So this is about your Jackson's thermal wound theory, which basically tells you the different forms of, or the zones of the burns that we have. Now, apart from that, we have based upon the burn wound depth only. So we have the classification of burn wounds based upon the wound depth. So talk about the latest classification that we have. So talk about the classification. That is classification of burns. And this is based upon the burn wound depth. Based upon the burn wound depth. Okay? Based upon the burn wound. That is the classification of burns based upon the burn wound depth. Now, I can classify them into following varieties. Number one, I can say there is superficial burn. It is a superficial burn, which is also called as the first degree burn. Then you have superficial partial thickness burn. You have superficial partial thickness burn. This is a superficial partial thickness burn, which is what we call it as a secondary burn, right? Then you have a superficial or deep partial thickness burn. We call it as the deep partial thickness burn. the deep partial thickness burn, which will be called as the third degree burn, and then you have the full thickness burn. Or I can say, rather than saying third degree, we call it as the secondary deep. So the secondary deep. Then you have the full thickness burn. You have the full thickness burn, which is what we call it as a third degree burn. There was another one that's called as a fourth degree burn, where there's involvement of underlying structures or tissue. But now the latest classification has merged the third and the fourth degree burn here only. Okay? Now, what are the on what basis are you going to consider all this, right? The criteria of considering various components here is going to be pain in the component of blister. We see the color of this, but more importantly, I should have added, okay. First, we'll consider the structures involved. It is the structure that is going to involve. Obviously, the second component is pain. Then you have blister. Then you have the color and whether it is going to heal or not. Whether that particular burn is going to heal or not. This is the criteria on which you're going to categorize the burn into different grades, or I can say different classes of burns that are present. Now, when we say that you have a patient who's got a superficial burn, here the structure involved is only going to be epidermis. Here the structure involved, it is only going to be the epidermis of the skin. Here it is going to be the epidermis of the skin. Here it is going to be the papillary dermis of the skin. Here it is going to be the reticular dermis of the skin. Here it is going to be the reticular dermis of the skin. Here it is the full thickness of the skin. Full thickness of the skin or involvement of subcutaneous fat, or there is involvement of underlying muscle, vessel, bone or tendon. If any other underlying structures involved, we'll finally classify it as third degree or also called as the full thickness burn. Now, pain is something that is going to be present if the skin is intact, and majority of the pain receptors are concentrated in the papillary dermis. If the papillary dermis goes, the pain will also disappear, right? So when you look at this, the first degree burns or superficial burns are extremely painful. The second degree superficial is also painful. The secondary deep does not have any pain, but they have something called as pin prick sensation. So when you look at these patients, there will be an intact pin prick sensation. That means you touch, there will be no pain. But if you take a pin and prick it, that sting will be felt. And that is what we call it as the pin prick sensation. Full thickness burns, no pain receptors, there's no nerve endings present, hence there will be no pain at all. Now, blisters are something that you will see. Blisters are something that you are usually going to be seeing with wherever you have the skin appendages which are present. So I can say blisters usually not seen here. Blisters are the characteristics of superficial. Blisters may or may not be present in deep. There are no blisters in your full thickness burn. There are no blisters in the full thickness burn, right? When you look at the color, there will be blanching erythema here. What is a blanching erythema? Is this presence of redness. When you exert pressure, it disappears. Superficial mein, there is non-blanching. There will be non-blanching erythema. That means you exert pressure, it won't go away. Here you have mottled pink appearance. Here you can have mottled pink appearance, or it can also have a waxy white appearance. Third degree of full thickness burn is going to have leathery. It can have leathery appearance or burnt like a charcoal, which is what we call it as a charred appearance, or we call it as a charred black appearance, right? Now remember, your first degree will heal, the second degree will heal, the second degree deep will also heal. This will not heal, this will require some form of an intervention. It will require some form of an intervention that we will look across at what form of intervention does this require. Okay, so this is the classification of the burns based upon the depth of the burn that is involved. Now see, whatever we have spoken about burns is the initial assessment. So until this point, you should know that how do you assess a patient of burns and how are you going to take it forward. Okay, so we started with the basic protocol that how does a patient, when he comes to the casualty, how are you going to address it? I'm going to do a primary survey. While I do the primary survey, I'll take care of this, that is usage of face mask with 100% of oxygen, 2 large IV cannulas, so that I can resuscitate the patient and give a tetanus toxoid injection. Look for warning signs if you want to intubate the patient. The warning signs are going to be the hoarseness of voice, inspirated stridor, presence of facial burns, as well as wheezing. If none of them are available, switch to secondary survey. The secondary survey is where you do the percentage of body surface area burnt assessment. Look if it requires wound debridement or not. If it requires, then you look for viable, non-viable tissue. Non-viable will require skin grafting, or a flap reconstruction. Viable tissue would require basic dressings and topical management. Now, how do you manage on a secondary survey protocol? The first thing that you have to give is a thorough wash. You need to understand what is the objective of giving a wash. The objective of giving the wash is not to make your wound sterile. It is to allow that cool down effect. Remember, another very important thing is, in this wash that we have given, until what time is the wash effective? That means I have a patient who has presented to you with burns, right? Now, if the patient had a burn at morning 6 o'clock and patient presents to you at evening 6 o'clock, will this wash make any sense? By that time, whatever heat has to dissipate into deeper tissue is already done. The damage is already done. Your wash is not going to help. So this will only make sense if the patient presents to you within 1 hour of burn. If the patient presents to you within 1 hour of burn, this remains effective. If patient presents after 1 hour of burn, this will remain ineffective. Then you look for the criteria for admission. When would you like to admit the patient? All these are the scenarios where you would like to admit the patient. And then look for the assessment, and the standard common assessment that we do is what we call it as the Wallace rule, also called as rule of 9. The adult and child have two distinctive components. The difference you have to remember, in adult the head and neck is 9%, in child the head and neck is 18%. In adult, lower limb is going to be 18%, child is going to be 14%. Adult perineum consists of 1%, child we do not consider perineum as separate. So this is what we call it as the Wallace rule, or also commonly called as the rule of 9. You need to understand the definition of significant burns. We have given you age-based criteria and the Jackson's thermal wound theory, which this divides the burnt area or the burnt site itself into three distinctive zones to tell you that the outcome of that burn depends upon how extensive the damage is. You can see in the center you have the zone of coagulation. Bigger the zone of coagulation, that means more extensive damage. Smaller the zone is going to be a relatively lesser injured wound. So managing becomes quite easy in that context. Now, based upon the depth, now see, many times in the exam when they ask you a question, they would not ask you on this basis, but they'll ask you with this criteria, right? They say presence of a non-blanching erythema, there's no blisters, extremely painful. What is the depth of the burn? The answer is going to be superficial. It is only epidermis that is involved. If they give you pale waxy white in color, there is presence of blisters are present. Then what is then? So when you have blisters, pale waxy white or mottled pink, it is going to be secondary deep in condition, right? Yeah. So they've been asking you many times about how do you calculate the percentage of body surface area burned. Yesterday, all those students who have written their FMG exam, they would know that there was a question that was asked to calculate the total body surface area burnt in a child, was asked on the basis of Wallace rule. Okay? It's a very, it's a high yielding topic, not only from the exam perspective, but even if you're in your casualty, in your internship or in your residency, that rule comes very, very handy. Okay? So this is what I would like to discuss on the first part of the burns. We'll continue tomorrow with the burns. Now tomorrow we'll talk about the resuscitation protocols. We'll talk about how do you manage a burn wound. We'll look for the special types of burns that we'll discuss tomorrow. That means we'll talk about frostbite, we'll talk about burns due to scalds, alkali burns, acid burns, and all those managements will be dealt tomorrow. Okay? So with that, thank you so much for joining BLS today. All those guys who are watching live, if you have any questions, any queries, reach down to me anytime you want. You know where to find it. We have in the Instagram, it is called as the surgery guy. The same you will find in the Telegram as well. This is by my name. It is your Dr. Sandeep Seeram Reddy. If you have any questions, any queries, feel free to reach out. This is the Telegram as well as this is the Telegram as well as the Instagram that you can reach out to us, right? Thank you so much for joining. See you tomorrow, same time, 9 o'clock, 9 to 10. We'll discuss the further component of burns and finish the burns management. Tomorrow would be probably the last lecture, or day after tomorrow would be the last lecture of trauma. And then after trauma, we will start the BAP of the entire general surgery. That is going to be GIT. Okay? So after that, we'll start GIT from the next week onwards. So this will be the last week of trauma, and we'll conclude trauma by this week, right? So thank you so much for joining. See you guys tomorrow at 9 o'clock. Bye. Good night.